Now we are going to do the upper one.
Very thin bone at the back, sir.
Yes.
Almost no bone in 6-7.
Yes. See, now because of periodontal issue, all the teeth are coming out like this. You can see the concavity in here also, the premolar concavity. So first bring it into the SCSE classification.
Complex.
So the sinus determines the SCSE classification primarily. How much it is front. Probably this is canine mostly, right?
Yes.
Okay, this canine is the second premolar. This is the second premolar. Okay, here canine will come. Exactly in the buttress area, mostly the canine will come. That means this is probably second. First see the sinus. Draw the sinus. Sinus is very close to the alveolar floor. Very close. We are also very close. Both sides they have come till here. So we cannot place the implant straight here, right? We can tilt it from here. We can tilt and reach this mesomaxillary buttress, and we can reach this area. We can tilt from this area. There is minimal bone is there, right? We can place two anterior implants and two territories. Imagine if there is bone here.
6.
Right? What we can do is we can place one implant here, one implant here, one implant here, one shot, and we can finish with a single piece cement retaining. Since the sinus has been resolved very much, we are planning for MD implants. So today also we have to be prepared for the bleeding. Okay. So we will see. So one way to reduce bleeding is to give mouthwash 3 to 4 days before surgery, 3 or 4 times a week, or do a mild scaling, superficial scaling. The bleeding will reduce, and give antibiotics for 1 or 2 days before starting the procedure.
Doxycycline.
Yes. And even you can give a Stolin gum paint to use for 1 week. That also will work. And if, before starting the surgery, you have to ask the patient to use mouthwash for at least 5 to 10 minutes. That also will reduce the bleeding and contamination also. First we will see the anterior implants. First we will see the canal. Okay, this much big, that one. It is opening as 2 foramens. Foramen of stencil, right? No, stencil is parotid, no? What is the name of the foramen? Some name is there, some person name. One is opening here and one is opening here. Sometimes they fuse and open as a single one. There are various shapes and types. But what is our concern is how much big it is. The more big it is, the more difficult for us to place the implant. We will see another patient where it is more bigger. It is like something like this much big. It is occupying the entire thing. So here, there is one technique. We can place implant exactly in the nasopalatal canal itself. Of course, we need a bigger diameter. Yes, exactly into the nasopalatal canal. We can just remove the content and delete and place it. And there is one more technique. This we can place implant anterior to the like this. Okay, palatal approach.
Yes.
But we are going in near the canal. You start the drill from here and you go. So we need bone here. If you have good bone here, we can apply this technique. When there is no bone everywhere, no, at least. So this is called nasopalatine canal implants or nasopalatine canal area implants. Either into the canal or just anterior to the canal we can place, but there is no need here. First we will see the 1-2-2 area. So this is 1-2 area. Sometimes there will be severe bone loss here because of pedontitis. No? So at that time you have to go for midline. So how will you place the implant here? This drawn. So this is the scenario. Almost 8 mm is there. It will be 2 mm, 3 mm with this drop where you can place the implant.
Yes. First we will do annuloplasty.
Yes, mild annuloplasty we can do till
Here.
until here. Yes.
And after that, palatal approach
Yes.
will be better. Like
Okay.
all of this.
Okay. So annuloplasty till here. So usual style is drilling like this,
Okay.
right? But you won't get much stability with that.
Okay.
What this poor bone, and this good bone. But if you start the implant here, it will get support from this good quality cortical bone, and you can place it. If you place like this, you have to bend also
Yes.
to correct angulation, which is not possible because already a thin bone. Yesterday we saw
Yes.
bending his head on sound. So this is abutment wise also this is better. Anchorage wise also it is better. The only thing is your threads, 1 or 2 threads may get exposed, but that is not a problem theoretically and practically also.
So here we can use KSO EX,
No, BCS EX.
BCS.
BCX is not available with multi-unit. Yes. And there is no need also.
No.
No need. Even conventional implant, people are doing palatal approach.
BCS or EX is available easily, sir.
BCX.
Yes.
Yes. You can get from Supraland. Only that company is
Having
I think it's little more expensive than BCS and this. So almost 10 mm implant we can place. So main thing is go close to the canal but not into the canal. So the 2-1 region also will be similar. We can see that the heart shaped
Yes.
canal. Here also we can place the palatal approach. You can see the value here, 1500, and palatally also it is 1100.
Yes.
Okay, so we will be getting from this 1100 good quality bone and 1500 good quality bone. So even though it is only a 10 mm,
Yes.
you can get a good support from it. So 2 implants anterior area, they are the key implants. Now we will plan for the